Hello there, I'm Dr. Thomas Martin from the University of California in San Francisco, and we're here today with Blood Cancers Today, discussing bispecifics and how we incorporate these new novel therapeutics in our treatment armamentarium for relapsed multiple myeloma, and I'm joined with several esteemed colleagues.
Hi, I'm Angela Dispenzieri, Mayo Clinic, Rochester, Minnesota.
Hi, Ajay Chari, recently at University of California, San Francisco as well.
Ajay Nooka from Emory University.
How are you guys doing dosing, say, of teclistamab after the first few months? Do you go to a less than weekly dosing? How do you do it?
So in order for us to uniformly give these agents, what we've decided was to follow the same schedule for in the first month, just like how we do the Velcade. So the bortezomib dosing of 1, 4, 8, 11. So we're using the first week 1, 4, 8 for all these. And as we move forward after the first 2 months, so alternating it to every other month, and after the first 6 months going on to a monthly basis. So I see that there is adequate data that is being built up in order to see, do you really need to hit so hard when you achieved a good response? And this dosing schedule might allow us to minimize all the toxicities that Ajay was mentioning.
So we do the same thing after 2 or 3 months, especially if they're in response. We go to every other week dosing for a couple more months, maybe 2 or 3 months, and then to monthly pretty quickly. And it's nice to actually have to come just once a month, for that therapy. So I think there's also new data that shows that perhaps there are less infections over time with less frequent administration. So I think we're all getting to that point where we have to do less frequent administration. When you guys send people to the community, after you've treated them, at your center for a while, any tidbits you give to the community docs? Any sign out, any handoff?
I'll pass. Because I haven't really done a lot of handoff at this point. We've really sort of held on to a lot
You
of
keep
our
them there
patients.
for that, yeah.
But there is some starting, but just people aren't there yet, so.
Same, yeah, we were.
Yep.
I don't think the community was ready and up and running.
So the Bay Area community is quite aggressive, actually. So we have done some of that, in fact. And so really what we tell them is what we just talked about over the time, that you still have to worry about infections. You got to make sure that they take their prophylaxis. And we continue, we actually follow CD4 cell counts, and we do, PJB prophylaxis, and as long as their CD4 cell count is low, they remain on it. And then acyclovir forever, and plus a few months, 3, maybe 4 months, till they're off that.
And nobody does antifungal. We don't, but nobody does, which is a difference from a lot of other things. You treat your acute leukes, your transplants, you're doing antifungal, but that prolonged neutropenia isn't there, and so it's everything but.
Yeah, the incidence of neutropenia is quite high, but it is just short. It's very short duration, right? So it's not that big of a deal.